Hello, I'm going to present on psychiatric interview today. In 364, you will be given a form for the psychiatric interview, but I'm going to deal with some techniques which can be used and what questions can be used in order to elicit information. Some essential concepts before we start the week one. So let's look into the essential components of the psychiatric interview. It's from the textbook Daniel J. Carlett. The first component is to build a therapeutic alliance. In the previous chapter about therapeutic relationship and communication, we dealt about the importance of developing a good therapeutic relationship. So we need respect, warmth, genuine acceptance, and also be yourself. Find a way of inculcating your own personality into your work. You will never enjoy psychiatry if you can't inculcate yourself and your personality and style into your own work. And second component is obtain the psychiatric database or get a good psychiatric history. Third is interviewing for nursing diagnosis. I modified a little bit from Carlett because it's interviewing for diagnosis. So nursing diagnosis, we are identifying actual or potential responses to the problems or stressors. So try to identify what may be the essential problems that we are looking for, and then based on that diagnosis we negotiate a treatment or to communicate to your patient. The treatment will be the clinician, so we here negotiate a plan of action or nursing intervention and communicate to the patient along with the patient. It is mutual, right? So that's all the essential components of the psychiatric interview. So let's look into the phases of diagnostic interview. That includes an opening phase, 5 to 10 minutes, and then there's a body of interview, and there's a closing phase. So it's the opening phase, which is 5 to 10 minutes, which we are meeting the patient and disclosing ourselves, like we are here and so, that's my name, and I'm here for the nursing assessment of you. I'll be taking care of you for 1 or 2 days while I'm here and learning. I want to learn a little bit about your life situation. Talk to the patient. Okay. So next phase of the diagnostic interview is the body of the interview. Here, which is about 30 to 40 minutes. Here we decide on some interviewing priorities to explore. For example, we need a format, a psychiatric interview format to go with. At least jot down points so that we don't sidetrack and get lost in the conversation. We need some certain aspects in our psychiatric interview to help the client. So which include history of present illness, past psychiatric history, family psychiatric history, present medical history and past medical history, social and developmental history, any assessment for suicidal ideation, homicidal ideation, history of depression, mania, looking for substance abuse history, and psychiatric review of symptoms, and also mental status examination. So this will help us to identify what's the patient's problems and overall what is the goal of this treatment or goal of this nursing action with the patient. The final phase is the closing phase, which is about 5 to 10 minutes. So you discuss your assessment with your patient, and if you have any patient education that needs to be incorporated, you could do that during this time and come up with a plan of action and follow up that you will come back and talk to you another time, and what helped and you need. And you explain to the patient, if it was an assessment, an initial assessment, you explain to the patient that, okay, you're here now and we have psychiatrists or nurse practitioners who will come and talk to you again, and they will advise treatment, and we have therapists and social workers and discharge planners who will come and talk to you and discuss about the treatment, and we have activity therapists, so you will go for different activities while you're here. Usual day of treatment is this many days, and you explain that. So as a nurse and as a nursing student, you will say that, okay, I'm gonna be here this many time for maybe till the end of the day, and I will come back only next week, and if I'll be able to see you, I'll come back and talk to you, but otherwise I would like you to work on what we spoke about, and so that's the closing phase. Again, looking at the therapeutic alliance, the feeling that you should create over the course of the interview, a sense of rapport, trust, warmth, being yourself, and giving the patient the opening word, diffusing the strangeness of the situation by starting with a social situation, or maybe like, I would like to know a little bit about yourself as a person. Where do you live? What do you do before you go into the depth of clinical interview? Next, I'm going to explain some of the techniques that you can use to while approaching threatening topics. First is normalization. So start the question by implying that the behavior is normal or understandable response to a mood or situation. For example, with all the stress you've been under, I wonder if you have been drinking more lately. To introduce a substance abuse topic, you could use that technique. Or sometimes when people are very depressed, they think of hurting themselves. Has this been true for you? Sometimes when people are under stress or feeling lonely, they binge on large amounts of food to make themselves feel better. Is this true for you? So you're trying different techniques to get this information. Another technique Carlett says about normalization is begin by describing another patient who has engaged in the behavior, showing that he or she is not alone. For example, I've seen a number of patients who've told me that their anxiety causes them to avoid doing things like driving on the highway or going to the grocery store. Has that been true for you? So the patient would be able to say, yes, it's not, he or she is not alone. There are other people who have similar symptoms. That is to assess the case of like agoraphobia or high anxiety when they go to different situations. Another example is I have talked to several patients who said that the depression causes them to have strange experiences, like hearing voices or thinking that strangers are laughing at them. Has that been happening for you? So here we are assessing if the patient has psychosis along with depression. So asking them if they have been hearing some strange voices or feels that others are talking about you or others are laughing at them. So has it been happening for you? So, but don't use, like for violence or sexual abuse, do not use normalization to ask about behavior such as violence or sexual abuse. Another technique like normalization is symptom expectation. That is, you expect the symptoms. That is useful when you suspect that some person may be using some self-destructive activity or they may be using drugs. So for example, in the scenario here, what sort of drugs do you usually use when you're drinking? If you strongly suspect some illicit drugs, you could use that way of expecting the symptoms. Another technique is symptom exaggeration. It is helpful in clarifying the severity of symptoms. Sometimes patient might minimize the degree of his pathology. So we can use this technique to identify how much they are drinking or how much they are purging or how many suicide attempts they have had. So this technique involves suggesting a frequency of problematic behavior that is higher than your expectation, so that the patient feels that his actual or lower frequency behavior will not be perceived by you as being bad. For example, how much vodka do you drink each day? 2-5, 3 more? Or how many times do you binge or purge each day? 5 times? 10 times? You must reserve this technique for situations in which it seems appropriate. For example, if you have no reason to suspect that a patient has a drinking problem, asking how many cases of beer he drinks each day will sound quite insulting. Another technique that can be used is reduction of guilt. This technique seeks to reduce a patient's guilt about a specific behavior. This technique is often useful in obtaining history of domestic violence or other antisocial behavior. For example, in case of domestic violence, you could start like, oh, when you argue with your wife, does she ever throw things at you or hit you? So the patient say, yeah, she should see the scar. She threw me away at me 2 years ago. So do you fight back? And patient would say yes, or how much ever he did. I have bruised her a few times. Nothing compared to what she did to me. Another example is, have you ever been in situations where fights occurred and you were affected? So this will help you to identify certain violence behavior or certain antisocial behavior that patient might have. So reduction of guilt in antisocial behavior. So in this technique can be useful to find out more details about legal problems that the patient has been in, or how many times the patient has been in jail, or so this will help us to identify more information from the patient. So have you ever had any legal problems? Patient might say, here and there, little stealing or stuff. Then, oh really, what was the best thing you ever stole? So the patient might say more about how much in depth it has gone to. Another technique that can be used is use of familiar language when asking about behavior. For example, you ask, do you shut up, instead of asking, do you have a history of intravenous drug use? Or do you ask, do you get high, or do you smoke dope, instead of asking, do you smoke marijuana? Or you could ask, do you snort coke or smoke crack, instead of asking, do you use cocaine? So using a familiar language, the patient will feel comfortable because they feel that the interviewer speaks their language. Some strategies to approach reluctant patients who are not trying to open up. So you could use open-ended questions there to increase the flow of information. For example, what kind of symptoms has your depression caused? What sort of things have you done when you felt manic? Or some open-ended commands to be more directive. Tell me what kind of symptoms you've had. Describe for me some of the things you've done while you were manic. So that gives you, these are like comments and more directive way of open-ended questions. Some other techniques are like continuation techniques that we also dealt in therapeutic communication techniques. Just saying, go on, really? Okay. Then giving a open posture. Okay, come on, tell me more about it. So that is the continuation techniques to help the patient to open up more. Another technique can be using a neutral ground. For example, when you discuss about psychiatric symptoms, some patients may be reluctant to open up. So you can change the topic to something non-psychiatric, asking about their school, or asking about their college, asking about their favorite subjects, and while talking through that, you can identify some of their frustrations, and then you can get back to the your history of presenting illness. Next is second interview. For example, if you're not getting anywhere with the patient in the first case, you can say that I can come back and talk to you another time, and you can cut the interview short for the first time. What are some techniques that you can use for an overly talkative patient? Using closed-ended questions, gentle interruption, and educating the patient about the need to move along in the interview. So for example, using closed-ended questions, have you been sleeping normally over the past week? Instead of how have you been sleeping? Or how many hours of sleep did you get last night? Another technique is using of multiple choice questions. For example, how has your appetite been over the past few weeks? Better than normal, worse than normal, or normal? Or what sort of sleep problem do you have? Problems falling asleep? Waking up throughout the night? Waking up too early in the morning? So these are some questions you could use for an overly talkative patient. Next is art of gentle interruption. So the next technique is the art of gentle interruption, also known as redirecting statement. So these can be in the form of three, like empathic interruption, delaying interruption, or educating interruptions. For example, in empathic interruptions, you soften the blow. For example, I can tell that this situation has been really hard for you to deal with. Have you been drinking lately to cope with it? Come back to the point of drinking. Next is delaying interruptions. So if the patient is talking about something or derailing from the topic, you can say that, I can see you feel strongly about your daughter's school problems, and that's something we can talk about later. But right now, I need to ask you about some of those signs of depression you were experiencing. Was your appetite normal through all of this? You're coming back to signs of depression, but you will come back to the daughter's school problems on a later time. Third interrupting method is educating interruption. This can be used only when the other two interruptions you've used several times with no results. For example, you say to the patient that you have some time constraints, you have only 20 minutes. I'm sorry, I need to interrupt you again. We need to cover about a lot of information. So I'm going to ask you a lot of questions. This may mean some interruptions, okay? And you continue. Or you may say, I need to know some important information about your appetite, your eating, any suicidal thoughts. So I may have to interrupt you to get that important information. So you're making that educating interruptions. So far, we have looked into some psychiatric interview techniques that we can utilize while we interview the patient. Now we'll look into some certain aspects of how to interview for suicidal ideation, homicidal ideation, how to assess for depression or mania, some essential concepts that you should not miss. First is suicidal ideation. We have some mnemonics, sad persons, and case approach for assessing suicide risk. I will explain in detail in the next coming slides. Next is assessing for passive suicidality, and assessing for active suicidality, and assessing for imminent plan. So that is the basic concepts while you deal with suicidal ideation. And then for homicide ideation, we need to learn the risk factors for homicide, ask about homicidal ideation, and know about your duties. Types of duties, that's a law. Let's say it's duty to warn. If you know that the patient has homicidal ideation towards somebody, you have the duty to inform that person. That is the terms of duties. These are some risk factors that you need to identify while you assess for suicidal ideation. It's a mnemonic that is used as sad persons, which is devised by Patterson. S stands for sex, that is, women are more likely to attempt suicide, but men are more likely to succeed. So the completed suicide is by men, but more attempts are seen in women. Then age. So there's a bimodal distribution when it comes to age. Teenagers and elderly are at highest risk. Next is depression. 15% of depressive patients die by suicide. So if there's a history of depression, if there's a current depression, that's a risk factor. Then a previous attempt. 10% of those who have a previously attempted suicide die by suicide. So if there's a history of suicidal attempt, there's a high risk factor there. Then ethanol abuse or alcohol abuse. 15% of alcoholics commit suicide. You hear that? 15% of alcohol use disorder patients commit suicide. Next is rational thinking loss. That is in case of a loss of reality, that is psychosis. Psychosis is a risk factor, and 10% of patients with chronic schizophrenia die by suicide. Then is social support, lack of social support. Then is organized plan. A well-formulated suicide plan is a red flag. If there's a good suicide plan, that is a red flag that the patient may commit suicide. Next is no spouse. Being divorced, separated, or widowed is a risk factor. Sometimes having responsibility for children is an important statistical protector against suicide. Next is sickness. Chronic illness is a risk factor for suicide. So you need to identify these risk factors when you look for a patient with suicidal ideation. Looking at how to assess the suicidal ideation, another mnemonic is used called chronological assessment of suicidal events, called CASE approach, CASE. So start by assessing the preceding suicidal ideation or event. Then elicit information about any suicidal ideation over the past 2 months. Explore past suicidal ideation. And then return back to the present and explore any immediate suicidality. That is called the chronological assessment of suicidal events. So start by today and then asking about last few months, last 2 months, and then asking about the past suicidal ideation, and then coming back and addressing more on the current suicidality. Some questions that can be helpful to assess suicidal ideation. Direct approach could be used. Have you felt suicidal? Have you had thoughts of wanting to hurt yourself? To assess passive suicidal ideation, you could use some normalizing questions, like sometimes when people feel depressed, they think that they would be better off dead. Has that thought crossed your mind at all? To assess active suicidal ideation, you could use some questions like these. Have you thought about suicide? What sort of ways have you thought about to hurt yourself? And to find out more about how elaborate and how realistic the suicide plan is, you could ask, have you thought about cutting yourself or taking an overdose? How close have you come to actually hurting yourself? Have you planned it out in your mind? Do you have a gun in your house? Do you have access to a rope? Do you have pills at home? And to assess the immediacy of the situation, again, you could ask, are you feeling suicidal right now? Do you have any specific plan to hurt yourself? What has kept you from killing yourself? And then you could ask, like, if you were to feel more suicidal over the next few days, do you think you could promise to pick up the phone and talk to someone before actually hurting yourself? Would you be in so much pain that you wouldn't want to ask for help? So these kind of questions will help you to assess the immediacy of the suicidal ideation or intention. Then is assessing homicidal ideation. Similar to suicidal ideation, we need to assess if the patient has intention of hurting others, or is it anybody in the unit, or is it outside someone, and who is the target of homicidal ideation? How serious is that? Is it a passive homicidal ideation, or is it an active suicidal ideation? How serious is that ideation? Is there any specific plan? And according to the Tarasov duty to warn, we have the duty to inform the police and also the victim. So as a student, you have to inform your instructor and also the staff nurses who are responsible for the patient, and they have the duty to further take up with the police and also the victim. So specifically assessing for some disorders, even though we're gonna deal with these in detail in the rest of the chapters, I want to give a few nutshell of what we're gonna deal with in the future chapters. So first is how to assess for depression. We like mnemonics, so this is called Psychiatric. We're looking for different characteristics of depression. A patient should satisfy a few characteristics from among these in 2 weeks period. So we can start with asking, how has your mood been recently? Have you been depressed? Have you been affected by depression for the last 2 weeks? And again, specifically ask about sleep disorder. You could ask about how's your sleep pattern been like lately? Do you sleep through the night, or do you wake up often during the night? What time do you usually wake up in the morning? Do you feel rested? And is there any difficulty with sleep? Next, to come to anhedonia or interest deficit, you could ask, before you felt really sad, what sort of things would you do for fun or for relaxation? So a patient might say some hobbies, and anhedonia means lack of pleasure, like the patient was having fun with certain hobbies in the past, but since few months or few weeks, patient is not interested or nothing is giving him any pleasure. So that is called interest deficit or anhedonia. So you ask, since you have felt depressed, have you noticed that you have been any less interested in these habits? Next is asking about guilt, like worthlessness, hopelessness, helplessness. Have you felt helpless, or have you felt hopeless during this time? Have you felt like you're not worth living? What do you see in your future? Or do you have hope that things will get better, or does it look pretty bleak? Other questions could be, for energy deficit, you could ask, how has your energy been over the past couple of weeks? Is this a change for you? Do you feel significantly more energetic before your depression? And then asking about concentration deficit, you could ask, have you felt more absent-minded than usual? Have you not noticed any changes in your memory? Sometimes patients can have difficulty making their decisions. So have you had problems making decisions? And also asking about appetite. You could ask, since you have been depressed, have you noticed that your appetite has increased, decreased, or stayed about the same? And about psychomotor retardation. Sometimes when people get depressed, they notice that their movements really slow down. Oh, has that happened to you? Or have you been more restless than usual? Have you been pacing or wringing your hands, unable to sit down for long? That assesses for psychomotor retardation or agitation. And then specifically checking for suicidality. So these are some characteristics for assessing depression. The mnemonic again is Psychiatric. So you look for sleep, you look for interest deficit, you look for guilt, energy deficit, concentration deficit, appetite disorder, psychomotor retardation, and suicidality. Then looking for mood disorders, maybe bipolar disorders. Another mnemonic is used called dig fast. That is to assess mainly mania. In order to diagnose mania, a patient should have certain symptoms for at least 1 week. Okay, 1 week of higher energy and grandiosity in flight of 5 years, and all these symptoms could characterize a bipolar disorder. So bipolar disorder itself can be 2 types, bipolar 1 and bipolar 2, which we'll go in detail in the next few chapters. But right now, so we'll just look at what is this mnemonic of mania tells us. So it's called dig fast. So some screening questions could be utilized. So you ask, have you ever had a period of a week or so when you felt so happy and energetic that your friends told you that you were talking too fast, or that you were behaving differently or strangely? Or has there been a period where you were so hyper and irritable that you got into arguments with people? Okay, if you have a positive screen, you further ask more about that. So you could ask like, were you having trouble thinking? Was this because things around you would get you off track, so you get easy distractibility? Okay, next is indiscretion, that is excessive involvement in pleasurable activities. So during this period, we've been talking about, how did you spend your time? Were you doing things that caused trouble for you and your family? Were you doing things that showed a lack of judgment, such as driving too quickly, running red lights, or spending too much money? Or did you do anything sexual during this period that was unusual for you? So you were asking about their judgment, excessive involvement in pleasurable activities. And then is asking about grandiosity. During this period, did you feel especially self-confident, as you could conquer the world? Or do you have particularly good news? Or did you feel that like you had any special powers? Did you feel more religious than normal? Then you could ask about flight of ideas. Did you have so many ideas that you could barely keep up with them? Were thoughts racing through your head? So were other people having a hard time understanding your ideas? So that is flight of ideas. And then increased activity. Were you more active than usual? Were you constantly starting new projects or hobbies? Did you have so much energy that you felt it was hard to calm down? And then sleep deficit. Did you need less sleep than usual? Do you ever stay up all night doing all kinds of things, such as working on projects or calling people? So that is sleep deficit. And about talkativeness. Did you find it hard to stop talking? Did other people tell you that they had trouble understanding you? Did friends have to interrupt you to get a word in edgewise? Or were you using the phone more than usual? Kind of assessing for talkativeness. So again, the mnemonic is dig fast, distractibility, indiscretion, grandiosity, flight of ideas, activity increase, sleep deficit, and talkativeness. So in the psychiatric interview, we looked at few techniques that could be utilized when we use our psychiatric interview format to assess a patient. So what are some things we have to look for when the patient is depressed? What are some things when we look for when a patient is had a history of mania? What kind of questions do you ask when you patient have suicidal ideation or homicidal ideation? So there are many other symptoms and many other questions that are incorporated in a psychiatric interview. We'll try to cover most in the coming chapters. Meanwhile, if you have any questions or comments, you can email me. Thank you.